Good morning, everyone. This is Morgan Edmonson with Evoke Neuroscience. Thank you for joining us for today's Lunch and Learn webinar. Before I dive in, I want to make sure that everybody can hear me loud and clear and that you can see my screen. So go ahead and navigate to your GoToWebinar menu and find the little box that says questions. I want you to type in there, let me know where you are today. I am in Northern California in Sacramento, state capital, and it's a beautiful summer day today. Hopefully you guys are having some good weather. Somebody's in Newport Beach, so that's got to be, what, 82 and perfect, as always. Wonderful. So it sounds like you can all hear me and see my screen, so that's great. Today, we're going to be talking about how to use your EVOX system to recognize neuroinflammation. And neuroinflammation, just immunology in general, toxicology in general, really complex subject. So we're going to try and keep it high level today. If you have detailed questions, now you know where your question box is. So go ahead and type in there as we work through the presentation. Let me know if you want to discuss anything in a little more detail. I'm happy to do that. I also want you guys to locate a PDF version of this presentation. That's in your handout section of your GoToWebinar menu. So I find sometimes it's helpful if you want to take notes or you just want to follow along, go ahead and download that PDF, and then you can have all of this content later on. Okay, we are going to jump in to our webinar. So a couple learning objectives to keep in mind just to structure today's talk. First off, we're going to talk about the basics of the neuroimmune response. We're not going into any type of detail. It's just going to be a quick review of the immune response in general in the peripheral nervous system and how it can affect a neuroinflammation in the central nervous system. I want you to be able to name neurodegenerative and psychiatric disorders that can be related to neuroinflammation. Believe it or not, basically all of the medical conditions we deal with on a day-to-day basis can have a huge interplay with neuroinflammation. I want you to be able to name lab tests that are relevant to the inflammatory response. And then recognize beta spindling from your raw EEG data that you'll get back on your EVOX assessments. I know usually we play in the quantitative world. We are going to be talking about how to interpret head maps. That's our last learning objective of the day. But I want you to recognize beta spindling as well. So we'll talk briefly on that raw EEG signal. And finally, I want you to be able to describe a couple other neurophysiology biomarkers that tend to go hand in hand with neuroinflammation, not necessarily representative of neuroinflammation in and of itself, but a lot of biomarkers that you'll see that kind of go along with this type of pattern. So starting off, diving in, what is neuroinflammation? We know that it's inflammation of the nervous tissue, and it's initiated in a response to really a variety of different cues. So things like infection, traumatic brain injury, exposure to toxins, autoimmunity. And really, it's a complicated subject. It involves immunology, toxicology, and honestly should be an etiological consideration for all conditions you're considering, including psychiatric conditions. There are positive and negative aspects of neuroinflammation, really depending on the intensity and the duration of inflammation. A brief and controlled inflammatory response is generally considered beneficial to the host organism, so to the human body, to fight off anything bad that could have entered your system. But really, it's chronic inflammation that tends to be the problem. So when we talk about neuroinflammation as a whole, generally, we're regarding this as chronic inflammation as opposed to acute. Now, acute inflammation is usually going to follow as a result of injury to the central nervous system as an immediate response. So that's going to be characterized by inflammatory molecules, endothelial cell activation, tissue edema, all of that type of molecular cascades that go along with a physical insult to the central nervous system. Now, chronic inflammation is different. That's really the sustained activation of glial cells, which we'll touch on, and recruitment of other immune cells into the brain. So it's this chronic inflammation that's typically associated with a number of disease states. We're talking neurodegenerative diseases, psychiatric disorders, and really just reduced neuroplasticity and cognitive impairment that can result in neuronal damage. So it's this chronic state that we're going to be talking about today. Now, of note, I want to talk about how the peripheral inflammatory conditions can influence central nervous system processes and result in this brain-related pathology that can cause alterations in mood, cognition, and behavior. So today we're going to be talking a little bit about the gut-brain connection and how inflammation in the GI system can actually impact the brain, cause neuroinflammation, and trigger essentially a number of different alterations in mood, cognition, and behavior. So first, breaking down just super high level the immune process. So we know that macrophages are going to mobilize whenever there's an introduction of some type of pathogen to the body, and their job is to rid the body of these foreign invaders. Ultimately, molecular cascades will cause release of cytokines and chemokines. Now, chemokines are going to draw immune cells toward the area that's under assault, and notably, where there are pain receptors, a pain sensation is going to be processed by the brain. So when you have an inflammatory process like a rheumatoid condition, you're going to experience pain in joints and tissues that are affected because there are pain receptors present. A little bit different if you have neuroinflammation. There are no pain receptors in the brain. So the brain doesn't have any type of way of acknowledging, yes, I'm experiencing inflammation because of the lack of chemokines and pain receptors in the brain. So cytokines are going to influence vascular flow, and by way of active transport, these guys can actually cross the blood-brain barrier, and they're really going to facilitate the immune-brain connection. So cytokines are kind of our key way of how peripheral inflammation can induce neuroinflammation. So these cytokines are going to impact the central nervous system in 3 different ways. One, they can be actively transported across the blood-brain barrier. They can also diffuse across a weakened blood-brain barrier in cases of weakened blood-brain barrier, which we usually associate with things like a head trauma. Now, once they get across that blood-brain barrier, enter the central nervous system, they're going to activate microglial cells. And microglia are such a hot topic in the world of neuroscience right now, and they have been for the past 5 years to a decade. And really, these guys are the main immune defense in the central nervous system. They're going to respond to what were once external cytokines, and then themselves produce internal cytokines that result in neuroinflammation. So really, you can think of the microglia as the macrophages of the brain. Now, chronic cytokine presence in the brain is not a good thing, and it's actually going to reduce mitochondrial function. Now, reduced mitochondrial function is going to mean impaired ATP production, right? So if we have ATP that's hindered by inflammation in the brain, a prominent symptom is going to be a lack of cellular energy. We know that our cells are powered by ATP. We need that ATP. And it's going to lead to an associated hypofunction of the brain or in peripheral inflammation cascade, the body region that's involved. So it's really all about these microglia and this cytokine presence that triggers neuroinflammation that can hang out for a really chronic type of a way. And when we've got that chronic neuroinflammation, a host of associated diseases are known to link between neuroinflammation and the disease state. So neurodegenerative diseases fall under this category. Alzheimer's disease, it's being increasingly understood that the inflammatory process is what's producing some of the biomarkers that we've heralded as the cause of Alzheimer's for the past 20 years. The inflammatory process in Alzheimer's is getting more and more attention. If you guys are attending any of the talks at the AAIC conference that's going on this week, actually, a huge amount of the conversations have been around kind of microglia, the inflammatory cascade, and how this is happening really early on, decades before symptoms. Parkinson's, a leading hypothesis of Parkinson's progression is that stage 1 actually begins in the gut, and the inflammatory response in the gut plays a key role in the alpha-synuclein aggregating and misfolding. MS, same story. Inflammatory cytokines are going to disrupt that blood-brain barrier like we talked about, which allows for the migration of the peripheral immune cells into the central nervous system, which isn't good. Once they get there, B cells and plasma cells are going to produce antibodies that work against the myelin sheath that is insulating neurons, and the degradation of myelin is going to slow conduction in neurons and ultimately contribute to the common symptoms that we characterize as MS. So inflammation is kind of one of the leading hypotheses. Inflammation is where MS really begins. Autoimmune diseases, of course, play a huge role here. Interesting, so does diabetes. Type 1 and type 2 diabetes have an effect on the brain because diabetes increases blood vessel damage over time, and the small blood vessels in the brain aren't an exception. So neuroinflammation is going to occur there as well. Of course, fibromyalgia, and then interestingly, psychiatric disorders. Oftentimes we don't really think about psychiatric disorders as a link to or related at all to neuroinflammation, but an emerging theory is that stress really plays a key role in initiating the deregulation of the immune system in psychiatric diseases. Of course, you're going to have genetic, epigenetic, and environmental factors that play into this, but it's the immune system activation that can be seen to cause abnormal neurotransmission, which results in serotonin deficiency, increased production of neurotoxic substances, and it's just all going to add to disease progression. So a great example of this is depression. Lots of research actually has shown that depressed patients are found to have greater TNF alpha and internuclein 6, along with less TGF beta. And autism as well shows patients have less TGF beta. So these are inflammatory markers, blood-based biomarkers that are certainly affected in these psychiatric disorders. So it really is, there's a strong link, a strong correlation between neuroinflammation and alterations in mood and cognition that we will then label with an appropriate neurodegenerative or psychiatric disorder. Now, I want to note that neuroinflammation as a whole really can lead to a disruption of hippocampal neurogenesis, which is very bad, right? We need this hippocampal neurogenesis for maintaining our cognitive functions, our cognitive connections on a neurologically based level. So neuroinflammation, regardless of what disease state you have, regardless how that neuroinflammation is manifesting behaviorally and symptomatically, this disruption to hippocampal neurogenesis is going to be seen pretty widespread if it goes unchecked. So lab tests can be a great way to start here, or a great way to follow up your EVOX assessment with. It kind of depends on your workflow and what you're doing and what your preference is. But I thought this would be a good opportunity to just list a couple baseline lab tests when we're talking about the world of neuroinflammation. These are the guys that you should be checking out. So looking at the erythrocyte sedimentation rate, C-reactive protein, antinuclear antibodies, interleukin-6, hemoglobin A1C, all of that good stuff is going to be really important in your kind of autoimmune workup or neuroinflammation workup, just to get a little bit more insight into what neuroinflammation cascade is actually happening. Of course, these lab tests aren't actually going to tell you where in the brain the neuroinflammation is occurring, and that's a really important piece to know in order to understand the disease etiology. So really, we recommend pairing any of these lab tests that you may already be doing with the EVOX assessment. And the reason why is because EVOX gives you access to qEEG, right? And we're looking for a neuroinflammation qEEG signature, if you will. Unfortunately, this time around, we are looking for basically just one pattern, which is the brain on fire, which is going to be reflected in our qEEG head maps, and it's represented by an excess of beta. So a healthy brain, we're looking at green, and neuroinflammation, as you'll see, is bright red. You can really easily remember this by just looking for the brain being on fire, if you will. So breaking down a little bit more about what's going on in an EEG, we know that neurons communicate via action potentials, which are created by the exchange between sodium and potassium into and out of the cell. So when this wave of ions reaches electrodes that are placed on the scalp, they're going to push or pull electrons on the metal surfaces of that electrode. And this push-pull difference is measured as voltage across time, and that's how you get the squiggly lines. Now, with the EVOX assessment, we're breaking those squiggly lines down into this EEG frequency spectrum, where we're mapping amplitude versus brainwave, essentially. So we've got frequency on the x-axis, 0 to 30 hertz, and amplitude on the y-axis. And essentially, we are producing all frequencies at all of the time throughout the day. But the power or the amplitude of each frequency changes based on the patient's physiological state or disease pathology. So quick review of our frequency bands. We know that delta is our slowest brain waves related to slow cognitive processing, things like sleep. A little bit faster, but still considered slow, is theta. That is basically a drowsy state or a brain kind of checked off daydreaming state. Alpha is kind of our intermediate bridges between slow and fast waves, and we're producing mostly alpha most of the time. That's why in this power spectrum graph, you see a huge spike in alpha. That's normal for a resting EEG. And then our fast waves, which we're going to talk a lot about today, are beta waves. These are our active waves. They are also the largest range in our frequency spectrum. So they range all the way from 12 to 30. We like to break it down into two separate groups, beta 1, beta 2, and you'll see why in a moment. So our fast waves is really our focus today, our beta waves. So when we do a database comparison, we're essentially asking, what does my patient's brain look like compared to our healthy controls? And if you're familiar with the EVOX assessment, you know that we graph this using a color chart. So blue is going to be a deficit of power, red is an excess of power for that particular brainwave frequency. And these colors really just represent z-scores. So how many standard deviations away from normal is your patient? And we map it onto the heads. Super important in cases of neuroinflammation to really consider the region of the brain where neuroinflammation is occurring. And that's what's really helpful about doing this type of electrophysiology test, either in addition to or sometimes in place of your lab tests, because it's showing you like where the culprit is, like where this dysfunction is really occurring, which of course is going to link back to symptoms and really help you understand what's going wrong with your patient. So when we interpret head maps, 3 things to consider. Of course, what frequency are you looking at? Is it a slow frequency band or a fast frequency band? And that's really because frequencies relate to disease pathology. So when you see alterations in delta, oftentimes that's going to relate to cognitive impairment. Theta will relate to cognitive impairment as well, and also attention. Alpha is going to relate to mood disorders. Mood often shows up in alpha. And then beta has a variety of things going on. It can be mood, it can be psychiatric disorders, stress disorders, and as you'll see, neuroinflammation. So really important to keep in mind what frequency band you're looking at. And then, of course, what power? Are you looking at red or are you looking at blue? Ideally, we're looking at green because that would mean your patient doesn't differ from the norm. But otherwise, we're keeping in mind, is it a deficit or an excess? And then finally, what brain region has gone wrong? Our brain regions are going to really relate back to the symptoms that the patient is experiencing. So if you have a problem in the frontal lobe, the patient is probably going to be experiencing emotional and behavioral control problems. So this is what we would call our quantitative EEG, right? There's really nothing subjective about this. It's all based with algorithms and math and database comparisons. Now, when we talk about beta spindles, that can lean a little bit more subjective because it's up to you with your eye to identify what are known as beta spindles. So here we're talking about raw EEG. And our beta spindles are going to be basically abnormal beta activity that usually exceed 20 microvolts. So essentially, you're looking for a really densely packed squiggly line group, and I've circled them in red here. That's the simplest way to describe it. You're looking for beta activity, so you know it's going to be lots of squiggles in a row, and spindles are really grouped together. And it's worth noting that there's kind of a waxing and waning feature to these spindles. So it's not going to be tightly packed for the entire 10-second duration of EEG signal, which is what we give you on the comprehensive report, is that 10-second segment of raw EEG. So you won't see beta spindling for the entire 10-second segment. You're going to see it in tiny little chunks as it is here. And oftentimes they're going to kind of show up in frontal electrode locations. So here you can see that they are both in frontal leads. And really these beta spindles are characteristics of cortical irritability, viral or toxin exposures, and can also be seen in epilepsy. So when you see these spindles, it does not mean necessarily that you're dealing with an epileptic patient. It doesn't even necessarily mean that you should be referring out to a neurologist if you are not yourself a neurologist. But these beta spindles can be related to neural inflammation. They're usually going to go hand in hand with our QEEG signal of neuroinflammation, which is on the next slide. But just wanted to review, I know some of our physicians aren't very familiar with why we even give you a section of the raw EEG data on the comprehensive report. And this is one of the reasons why we want you to be able to recognize beta spindling. And really the only way to do that is for you yourself to look at a snapshot of the raw EEG. So you're looking for those tightly dense little squiggles up and down just for a split second, and then they're going to go back away. All right. So getting into our head maps, QEEG and neuroinflammation, what are we looking at? This is an example of neuroinflammation, right? We see an excess of power in essentially all of beta, and that is our brain on fire pattern that you're going to keep an eye out for. But it's worth noting that different brain regions and different frequencies within beta can mean different things. So I'm going to walk you through a kind of a breakdown of the different components going on here. So first, starting off with the temporal lobe, in this case, there's actually a lot of excess temporal activity in beta 1 and in beta 2. So if you see it in beta 1, that's kind of, if you split the beta range in half between 12 and 30, beta 1's talking about 12 to 18 hertz. And if you see temporal excess in beta 1, that's going to be related to self-regulation difficulties, irritability, and also tinnitus can show up here. So always a good thing to ask about for your patient if you aren't already aware of that. And when you see it continue into beta 2, now you can be thinking maybe there's some type of autoimmune condition going on here, maybe temporal arteritis, vascular inflammation can show up here as well. Now, if you see spindling, that would be from looking at the raw EEG signal. Sometimes that'll mean mastoid muscle tension conditions, right? So you're thinking TMJ or just in general high stress. So it's not something that we want to write off as muscle artifact. Really, nothing in this graph shown here is muscle artifact. It's all neuroinflammation related to potentially autoimmune conditions, potentially self-regulation difficulties, and psychiatric conditions. We have to do a little bit of hunting and further investigation to figure out exactly what, but this is kind of a way to break down what's happening in the temporal lobe. In the frontal lobe, right, the frontal lobe is responsible for different types of functions. So when you see an excess in beta 1 in the frontal lobe, that can be related to an excess of norepinephrine. So usually that clinically manifests as anxiety, mania, or impulsivity. So now we're getting a little bit more into mood dysregulation. When it creeps into beta 2, now you're dealing with inhibitory dysregulation, so lots of cortical irritability. And bipolar symptoms can be seen in patients that have an excess of frontal beta 2. Doesn't necessarily mean you're going to come to a conclusion of bipolar right away, but just gets you thinking down that road. Now, when you see spindling in the frontal region, that's going to be due to excessive frontal muscle tension. And so that's usually seen as headache. So really important to always ask your patients when you see an excess in the frontal part of the head and that spindling, you want to make sure that they're not experiencing chronic headaches and it's just gone unannounced to you. And when we talk about the central region, lots of different disorders can come up here. So things like OCD, motor movement disorders, attention and sleep difficulties. And then when you creep into beta 2, it's important to consider medication side effects. So really notably, benzos and barbiturates are going to show up here as a possible medication side effect. So really important to keep in mind if you have a patient that is on barbiturates, it can show up here and it's not necessarily neuroinflammation. It very well could be a medication side effect. And finally, when we get to the back of the head, the parietal lobe, really we see patterns of negative rumination, fibromyalgia can show up here, as well as OCD. And when you creep into beta 2, we're dealing with hypervigilance conditions that hinder sleep. So you can tend to think of neuroinflammation as sometimes being correlated with kind of go, go, go mode, which oftentimes when we're dealing a patient with stress, if you viewed our stress webinar, stress can show up kind of in the same way as neuroinflammation. So it's really a question of knowing the patient, knowing their history and their symptoms of, do you feel like their brain is stuck in go, go, go mode, or does that not match their characteristic at all? And this is really a case of neuroinflammation. But worth noting that stress and hypervigilant conditions can show up in that same pattern, and that medication side effects can show up here as well for beta 2 in the parietal lobe. So that's a kind of an overwhelming breakdown of different brain regions and kind of beta 1, beta 2, and spindling, and lots of different correlations that can occur within this neuroinflammation pattern. So you can see that if this really is neuroinflammation and you do your lab tests to confirm, yes, this is in fact neuroinflammation, it's no wonder that psychiatric conditions could be popping up here, or sleep disturbance could be popping up here, or really just self-regulation difficulties. So I also want to talk about different biomarkers to keep an eye out for. These guys aren't necessarily representative of neuroinflammation, but they certainly are correlated with neuroinflammation. So first off, you might see an excess of delta or theta as shown here in the graph on the right. When you see an excess of delta or theta, that's really correlated with fatigue and drowsy state, diminished cognitive processing, and just general cortical hypofunction. Notably, this is kind of a pattern you would expect to see in somebody that is experiencing dementia. Maybe you're an Alzheimer's patient. You're going to see an excess of this slow wave activity. We've talked about that a lot in our past webinars on how to recognize dementia. But it doesn't always mean dementia, right? In this case, usually when it's paired with neuroinflammation, it can indicate a metabolic or a hormone deficiency, can also indicate a focal brain injury or toxin exposure. So you have to do a little bit of investigative work in order to figure out exactly what's causing that excess delta theta. But it is common to see your neuroinflammation pattern in beta paired with some excess of your slow wave as well. Now, sometimes you'll also see an elevated peak alpha frequency. Remember, peak alpha frequency is that cognitive biomarker of just generally a reflection of cognitive capacity. Now, when you see it elevated higher or faster than 11 hertz, that's really representative of central nervous system over-arousal. So clinical symptoms of anxiety, insomnia, and hypervigilance are going to be related to this elevated peak alpha frequency. And that makes sense, right? If the brain is on fire and you have a lot of associated psychiatric symptoms that kind of goes along with that, you're going to see an elevated peak alpha. Now, likewise, you might see an elevated very low frequency breakdown of the heart rate variability. So here we're talking about that balance between sympathetic and parasympathetic. And when you see kind of dominance of the sympathetic domain, that's associated with conditions like anxiety, stress, insomnia, and pain. And neuroinflammation really goes along with a lot of those conditions, a lot of those symptoms. So oftentimes you'll see this sympathetic dominance go hand in hand with neuroinflammation patterns. And finally, on the behavioral side, it's common to see a delayed reaction time with neuroinflammation. Usually delayed reaction time when you're working with an elderly patient, reaction time is naturally going to get delayed with age. But things can go wrong and really hit that reaction time hard. Neuroinflammation is one of those. So when you see that reaction time start to slip, in this case, pretty severely outside of that normal range, that can be an early indicator of psychosocial stress and fatigue, and neuroinflammation really goes hand in hand with those. So I want to wrap up our webinar with a couple case studies. The first one is a 73-year-old female, and she actually was with a different physician prior to coming to one of our physicians. And that first physician gave her a diagnosis of Alzheimer's disease. She is ApoE4 positive. She had a family history of Alzheimer's disease and was really experiencing cognitive decline over the past 5 years. So she got this diagnosis. She was placed on a pretty expensive and intensive supplement protocol for about 10 months that was designed to kind of halt or slow the progression of her symptoms, and no results were seen at all. So when she came to one of our EVOX practitioners, the goal of that physician was to just simplify the life for the patient and the caregiver, because these supplements were extremely expensive. They were extremely involved in detail on what to take and when. And so the goal was just to simplify life for patient and caregiver. And this physician did an EVOX assessment to kind of get a baseline and understand what she was working with. And the EVOX assessment actually did not show a pattern of Alzheimer's disease. And that's pretty clear here, right? Peak alpha frequency of 10.7, that's fantastic. Yes, we do have indiscernible P3B, but when we look at our qEEG head maps, this is our clear-cut neuroinflammation pattern, right? We don't see our EEG slowing pattern that's representative of dementia and possible Alzheimer's disease. But we do see brain on fire. Everything in the beta range is red pretty much globally throughout the entire brain, all the brain regions. So now we know, well, this was actually not a correct diagnosis of Alzheimer's disease. This is neurotoxicity. And there's something we can do about that, which is good. So she had basically a new diagnosis, neurotoxicity, that the physician was actually able to relate back to water damage of the home that occurred around the same time that cognitive decline started to set in. So it's absolutely exposure to different toxins. A lot of lab workup went into this case study that found there was 4 different molds present, really high metabolites that were all related to this water damage, an excess of many strains of Clostridia in the gut, and really just all of this combined to create a lot of different inflammatory processes that ultimately led to this alarmingly present neurotoxicity. So a gut repair protocol was performed along with HIIT training and diet changes, and a follow-up from these are only about 6 months apart, and there's a striking difference. The brain has finally quieted down, that neuroinflammation has almost 100% resolved, and her symptoms also reversed, right? She was so much more herself. Her husband really credited this physician to kind of getting his wife back. So a really fantastic case study and a very cool baseline to follow up example of if you're able to identify neuroinflammation, yes, you have to do a little bit more investigative work to figure out exactly what's gone wrong and what's causing this neurotoxicity. But once you can do that and once you can clean it up, the brain really responds quite well. So a great example of recognizing neuroinflammation, treating it, and seeing the biomarkers return to normal. Another case study is with a patient on the opposite end of the age spectrum. So now this is a 4-year-old girl who really was presenting with severe anxiety, hyperactivity, insomnia, and psychotropic agents were having little to no positive effects at all. So a baseline assessment was performed, and you can see the same pattern of neural inflammation. Really here present in beta 2, so our fastest frequency band. Now, a very involved intervention here was needed. So different supplements, dietary changes. I know that she was put on a gluten-free diet. She was taking Epsom salt baths to get magnesium. And this was strictly adhered to, and 4 weeks later, in a post-treatment assessment, you can see that this neuroinflammation has really been resolved, and symptoms were greatly alleviated. So again, just a great example of how psychiatric conditions, as was the case, this little girl was presenting with a whole slew of psychiatric concerns. And it was really due to neuroinflammation. You get the brain to quiet down, you treat that neuroinflammation, and symptoms are going to be alleviated. So I think our last case study of the day is a 31-year-old female who was 3 months postpartum and presenting with blurry vision, dizziness, and migraine. So an EVOX assessment was performed, and a couple interesting things here going on. So we do recognize that pattern of neuroinflammation. It's not quite as diffuse across the brain. It's pretty concentrated in the temporal and parietal lobes in beta 2. So that does present as neuroinflammation and does explain her vision problems and her dizziness, right? You're talking temporal parietal, that makes sense, vision and vestibular system. Now, in this case, we also see an excess of delta and theta, and we talked about how that excess delta theta can go hand in hand, that general cortical hypofunction. Now, I want you to remember at the beginning of this webinar, we talked about how a chronic presence of cytokines in the brain is going to impair ATP function. that makes sense. If you've got impaired ATP function, you're going to get that cortical hypofunction, and it's going to display typically as an excess of delta and theta, as is shown here. And this really explains kind of behaviorally what's going on with her as well. If you look at her neuropsychological testing on the left side of the screen, she's got delayed reaction time variability, and that's a result of this excess of delta and theta. Now there's another little Easter egg in here. There's a pretty big excess in the back of the head at 10 hertz and 11 hertz. And this is usually a signature of PTSD. And especially when you compare it to the eyes open EEG head maps, you want to kind of confirm a diagnosis of PTSD in that way. So we're talking about this excess in the back of the head here. I've popped up our eyes open graph, and you can see it's no longer present in eyes open. And that is our classic PTSD. So this is actually a case of neuroinflammation that turned out this patient had a very severe motor vehicle accident 6 months prior to this assessment. She actually almost lost the baby. They were able to save the baby, but kind of neglected mom as a patient. And so she was experiencing all of these symptoms. And it's really related to neuroinflammation due to this car accident that did not resolve at all. So in this case, that interesting pattern you see is actually a counter coup of that head injury. She really hit the side and back of her head hard. And then it triggered this neuroinflammation cascade that ultimately led to diminished ATP, causing her this excess of delta and theta and cortical hypofunction. And she's been psychologically traumatized from this. She has PTSD related to the accident and really was not in great shape. But now we've recognized neuroinflammation treatment protocols in place to kind of to treat that, and also to treat the PTSD, the psychological component of that accident. So a couple final thoughts is I really encourage you to consider neuroinflammation early in your assessment and your treatment workup. If you're doing EVOX, it should be pretty clear and pretty easy to recognize neuroinflammation. And then oftentimes you're going to have to follow it up with blood labs, GI function labs, to kind of go hand in hand with that electrophysiology. So kind of in this case, when you're recognizing neuroinflammation, it's not a closed case, right? You still have to dig a little bit further to figure out what's causing the neuroinflammation, but at least you know that's what you're dealing with, and that it's something you can treat, and then hopefully symptoms are going to resolve. So that is it from me today. Thank you so much for joining for today's Lunch and Learn webinar. If you've got questions, you want to talk about all things neuroinflammation, I'm happy to do so. Shoot me an email. You can get me at medicalaffairs@evokeneuroscience.com. And likewise, if you're working through a challenging patient case, or if you want access to more clinical education materials, we talked a bit about PTSD today. We talked about dementia patterns. If you're not familiar with those things, we have them all on demand on webinars. So I'm happy to give you access to that material. Thanks again for joining, and take care, everyone.